My name is Brittany Garcia. I'm the program coordinator on the Texas Southern University side for the P20 Cured program. So for P20's webinar today, we are going to hear from a speaker about cancer prevention from a pharmacist perspective. Thank you again for joining us. If this is your first time, there will be a question and answer session at the end of the speaker presentation. And if you have any questions while they are presenting, please post your questions in the Q&A box. To just give a little background about the P20 Cured program, we're the Partnership Collaborative Union for Cancer Research and Educational Development. We have developed an alliance between Baylor College of Medicine and Texas Southern University for cancer research, education, community, and outreach. And so we do training through promoting the biomedical workforce, supporting a pipeline of collaborative innovative cancer research pilot projects. So this is the overview of the program and our amazing staff. We're doing the development of the cancer research workforce, improving effectiveness in cancer health research programs. We are addressing differences in breast and bladder cancer and future pilot projects, and just promoting wellness and health. So before I introduce today's speaker, just some housekeeping items. Make sure to complete the survey for community members. And if you are here as a CHW wanting to get a CHW CE credit, please sign in for that and then complete the evaluation survey on that. So today, our speaker is none other than Dr. Rodney Hunter. He is a clinical associate professor here at Texas Southern University in the College of Pharmacy and Health Science Department. He is also a clinical assistant professor at the University of Texas Health Science Center in Houston, McGovern Medical School, and clinical pharmacy specialist at UT Health Memorial Hermann Cancer Center in Houston. He has received his Doctor of Pharmacy degree from Texas Southern University, followed by a fellowship on oncology at the University of Texas MD Anderson Cancer Center here in Houston, and he is a board-certified oncology pharmacist. He is the program director of the T.L. Burks Breast Cancer Outreach Center and serves as an advisory board member for the Texas Southern University Breast Cancer Screening Prevention Center, which is funded by the Cancer Prevention and Research Institute of Texas. He is a principal investigator for the Artificial Intelligence Machine Learning Consortium to advance cancer health outcomes at TSU in collaboration with the University of Texas Medical Branch. Thank you so much, Dr. Hunter, for joining us this afternoon.
Thank you, Brittany. I appreciate that introduction. And I guess if you guys will let me maybe take over. Thank you so much. Let's see where we are here. Letting it flip over to presenter mode. Absolutely. So definitely a privilege to talk to the group today, and really want to go over, cancer prevention, but really looking at cancer prevention from a pharmacist perspective, because there's several things that I, as a pharmacist, am involved with in my clinical practice that are directly related to prevention. And you'll see that nutrition, exercising, really watching out the proteins and the components of the patient's diet, and also risk assessment tools that may qualify a patient to receive preventative medications or preventative surgeries, or things that I'm involved with in my day-to-day activities as a clinical pharmacy specialist at UT Health Memorial Hermann Cancer Center. So, just to begin with, these are like the four big ones that I'll hit. I'll actually touch on cervical cancer as well, but breast cancer, prostate cancer, lung cancer, and colorectal cancer, I have components that affect as far as healthcare disparities are concerned. Starting with the breast cancer, moving to the prostate cancer, where African-American males specifically have a higher incidence and actually have recommendations to have earlier screening. Lung cancer, which is always a tough one, really looking at preventative strategies and actually increased screening early on if you're a patient that has history of smoking. Specific types of history of smoking is something that I'll touch on just briefly. And then, with colorectal cancer, we actually have a lot of medications that patients may not be aware of that actually can possibly help with colorectal cancer. So, receiving direction from your PCP or your primary care physician with your assessing your risk of colorectal cancer. I have some things sprinkled in this presentation that may be beneficial or something you can at least ask those questions on. So just looking at let's looking at the history of analyzing cancer causes. Starting with breast cancer is by far the one we know the most about when you think about risk factors and different types of things that would possibly affect a woman. And actually, there's a minority of male patients, but definitely female patients and their risk of developing breast cancer. Was already established in the 1850s that there was a strong link with the family history of patients, first degree relatives having breast cancer, and the incidence of a patient having breast cancer if a mother or daughter or sister also had breast cancer. Going then down the line in the 1920s, there was identification of the reproductive risk factors. So, when you look at breast cancer, you look at the age of menstrual cycle stopping and starting. Both of those things are very important, and the amount of pregnancies that a patient has carried to term also affect the incidence and the likelihood of a patient developing breast cancer. The Lane Clapton case study, another thing that established some of the different risk factors. And then, as I mentioned before, menopause. Oral contraceptives were a very hot topic in the 1970s, to where the estrogen levels in oral contraceptives at that time was very high, which actually is a link and is a risk factor of developing breast cancer. Exogenous high doses of hormones. But postmenopausal hormones were, with the Women's Health Study, were the top reason or the cause of breast cancer, which is also linked to age. Diet, which is something I'm going to touch quite a bit on. I have a lot of information on some phytochemicals and things that can possibly be beneficial to prevent cancer. And then physical activity and obesity are things that have been discovered. They were initialized in 1970s, and we continue to do more studies and find more and more information on physical activity being positive as far as stopping the incidence of cancer in general, not just breast cancer. And then also obesity being something that's a risk factor. Endogenous hormones, and then selective estrogen receptor modulators is something that I'll talk about as far as being a weapon that we have to help patients who have a high risk of developing breast cancer. So phytochemicals, a lot of the things that patients come to me in the hospital setting or in the clinic setting, they want to talk to me about, they're talking to me about megadoses of phytochemicals. There's all types of things you'll see on infomercials, you'll see on social media that will try to lead you down a path of being something that cures cancer, treats cancer, stops cancer, all of these things. And some of these things that you see, they actually do have some data behind them. It wasn't in a controlled setting, so I had to answer these questions all of the time in my practice as a pharmacist about what is safe to take, what is good to take, what is beneficial, what is not beneficial, what is harmful. So when you look at phytochemicals, they may stimulate the immune system, which is one thing that can benefit patients who you're trying to treat cancer, because the immune system itself can actually destroy cancer cells. Blocking carcinogens, which is the leading reason why patients who get some type of exposure to something outside develop cancer. Really looking at chemicals and different types of things that will possibly cause cancer. Reducing inflammation, which is also linked to cancer. Preventing DNA damage and helping to repair DNA, because as the DNA continues to consistently get damaged, that can give rise for the cancer to develop. Reducing oxidative cell damage. So that's why you see very frequently, probably the top thing that you're going to see very consistently in a lot of things is that anything that's an antioxidant, and they think that decreasing that amount of oxidative damage to cells benefits or prevents cancer. Slowing the growth of cancer cells if your patient actually has cancer, or triggering cancer cell death, or regulating hormones. And the regulation of the hormones is very important when you're talking about prostate or breast cancer, because those two cancers specifically are driven by the male or the female sex hormones. So carotenoids, and I really just focused on the sources of these particular phytochemicals. There's about 7 or 8 of them that have been identified, but you'll notice they're in different types of fruit fruits and vegetables. So with this particular group, you see red, orange, and green vegetables and fruits is where you'll see these particular phytochemicals show up in decent amounts, and they have possible benefits of inhibiting cancer cell growth, improving the immune system response, and having antioxidant effects. And like I say, with the antioxidant effects, I'm always careful because there are certain treatments that we use and we utilize in clinical practice that work as far as oxidation is concerned. So if you take antioxidants with those particular agents, they actually are counterproductive. So I look and I analyze all of the things that patients bring to me when they want to take a over-the-counter agent that they've seen or somebody has told them works against cancer. So I'm very mindful to make sure that I'm analyzing what are the effects on the oxidative stress when patients are taking those. The flavonoids, you see apples, citrus fruits, onions, soybean, coffee, tea, all of these things actually contain these flavonoids, which inhibit the inflammatory process and possible tumor growth. They can aid in immunity, which of course your immune system is very important as it can fight off cancer. Some of the newest and most commonly used drugs most recently in oncology or cancer treatment in general really utilize the effectiveness of the immune system to destroy cancer cells. So the immune system is very, very important. And also boosting the ability of us to detoxify our body. So stimulating enzyme activity to detoxify our body, and those toxins being expelled or neutralized can actually help to stop cancer cell growth as well. Broccoli, cabbage, Brussels sprouts, kale. When you look at the endos and the glycosa enolates, they both affect preventing tumor cell growth, blocking carcinogens, limiting the cancer-related hormone production. And once again, those are some of your sex hormones like estrogen, progestin, and testosterone specifically, and then also inducing detoxification. And once again, the detoxification, very important because our body is fighting off more than people realize when it comes to cancer. We look at an inositol brand from corn, oats, rice, rye, wheat, all of which can possibly slow cancer cell growth. But then you have to be very careful when you're giving mega doses and high doses of it, because you certainly can have antioxidant effects, which is something that, depending on the therapy the patient is on, we want to watch out for. The isoflavones with soybeans and soy products inhibit tumor cell growth, inhibit cancer-related hormone production, and also have antioxidant effects. And I definitely mention this one, and like always, to watch out for soy, because our patients who are vegetarian, and of course, if you're vegetarian, you don't necessarily have to have a diet that focuses on soy-based products. But I always want to talk to my patients about this, because as I told you, I want to know if they're taking mega doses of antioxidants. And then also soy specifically possibly has these phytoestrogenic properties. And the reason why I bring those up is because they might be weakly estrogenic, which means that instead of helping, they can harm you if you have specifically breast cancer, because if some breast cancers feed on estrogen, so the more estrogen you have, the more the breast cancer grows. So that's something else that I bring to the table as far as being very mindful. A lot of this information I'm giving you certainly can be beneficial, and it can be beneficial by letting you know that maybe it's not something you should do, or something that if you are going to do, making sure you're consulting with your primary care physician or your oncologist if you're somebody that has been diagnosed with cancer, to make sure it's the safest and the best thing for you to do as a patient. Once again, going back to the broccoli and cabbage and Brussels sprouts and kale, detoxifying the carcinogens, blocking tumor growth, the antioxidants, these isothiocyanates, these specific chemicals are in these types of vegetables. We have several things that we identify as phytochemicals in these broccoli, cabbage, Brussels sprouts, and kale. And like I said, the antioxidant effects always would jump out at me when patients are telling me that they're taking like a commercialized capsule that's got, equivalent of, 2,000 Brussels sprouts in one capsule. And you'd be surprised at the things that are being synthesized and the things that are being made that are trying to extract these chemicals out of different types of things you would buy at the grocery store and put them into mega doses and then market them to treat patients with cancer. So I spend a lot of time on these phytochemicals because I think as a pharmacist in the cancer setting, I have the most conversations with patients about things that are not necessarily approved by the FDA to be taken for cancer, but I still need to analyze them. I still need to assess them for safety. And so this is why I spend, a decent amount of time talking about these phytochemicals. And as we get to the end with the polyphenols, green tea, grapes, wine, berries, whole grains, peanuts, once again, antioxidant effects, preventing inflammation, preventing cancer formation, of course, with wine. Certain amount of patients always ask me about wine. They like to partake in wine drinking, and they read different studies, and they do have information to say that wine and grapes do have these polyphenols, maybe what's responsible for them possibly having benefits as far as preventing cancer. Because like I say, antioxidants in general are certainly something that you can like speak to and you can identify as a reason why patients can develop cancer if they have too much oxidative stress in their body, but taking antioxidants calms that down. So as long as you're not taking a chemotherapy or medication that works in this same fashion with the oxidation, antioxidants are a consistent thing in the phytochemical effects that we can identify as being possibly beneficial. With the terpenes, with cherries, citrus fruit peel, rosemary, a host of different possible benefits with this particular group of fruits and vegetables and herbs. We're protecting cells against cancer, slowing cell growth, the strengthening the immune system, antioxidant effects is kind of like the consistent theme here, and also protecting patients against infections, especially if they actually are being treated and we're worried about the immune system being compromised, which can then cause an infection to happen, which sometimes is what causes me to delay my patient's treatment. So kind of to come to a whole stop on it and look at all of those different phytochemicals we're talking about, not grouping all of just identifying all of these fruits and these berries and things that are possibly beneficial. The apples, the blueberries, the broccoli, the garlic, grapes, grape juice, wine, tomatoes. There's a lot of things they have here that definitely have some strong chemical links to beneficial things when it comes to the prevention of cancer. So we certainly talk about a patient's diet consistencies. We want to know what is the proportion of proteins the patient is eating, fruits, vegetables the patient is eating compared to like fatty foods, foods that are high in cholesterol. All of these things are why you focus on cancer. There's a strong link between a lot of the things that we would usually talk about, which is like high blood pressure, hypertension, or high cholesterol, diabetes, all of these things, everything is unfortunately linked together. So, kind of to begin when we're talking about breast cancer. So when you look at risk factors, of course, the very small percentage of patients who develop breast cancer are male, but it can be diagnosed in male patients, female patients by far. As the older patients get, the higher the risk of developing breast cancer. Positive family history, specifically with first-degree relatives, definitely something that is important to assess and get information on from a baseline perspective with the patient. BRCA1, BRCA2 mutation. I'll talk a little bit more about it, but the reason why it's important is because, studies will show that maybe as high as 70% increase in the risk of developing breast cancer over a patient's lifetime is associated with the BRCA mutation gene, whether it's one or two. The onset of menstruation, the onset of menopause, also important things. Dense breast tissue. Sometimes patients in their younger years, if they have been diagnosed with different types of childhood cancers, can have exposure to radiation when they're younger, and that in turn increases their risk of developing breast cancer as they come of age. So also things as far as decreasing the risk, things you can control as patients, because that's what really where we're here. We're here to talk about things that you as a patient can control, and limiting alcohol use, consistent physical exercise and activity, maintaining a healthy weight. Hormonal blocking agents, and the reason why I have an asterisk there is because we're going to do a theoretical assessment. I'm going to take some time to do a theoretical assessment so you can see, and this is a website that's available to you as a patient. You can find it on the NCI website, and these are questions that you as a patient can answer. A healthcare professional doesn't have to answer it, but I'll show you what you can do with that information once you do answer the question. And then also preventative surgery. So some women who we identify early on that they're at high risk for developing breast cancer, we can do preventative surgeries where we're focusing either on bilaterally or both sides of their breast, removing those, or their ovaries, or a combination of the two. And that can at times reduce the risk of developing breast cancer by as much as, 90-95%, depending on what you're removing, or if you're removing the ovaries and the breast. So surgery is definitely an option in patients who are high risk, and something that will be offered to you if you get a proper assessment from an oncologist. So this is the tool I was talking about. It's called a breast cancer risk assessment tool, or it's an online calculator. And it was also termed the Gale model, that's they used to call it, but now they call it's an NCI tool that can be used. And I'm just going to go through it. I've made screenshots so you can kind of see all of the questions, but you can go to the website, and it's going to establish like your lifetime risk is actually developing breast cancer. So it's a pretty important tool, pretty useful. As you can see, the first kind of questions that it asks you, it's asking you about that BRCA1 and that BRCA2 mutation that I talked to you about, as far as it being already substantially increasing your risk. So this NCI tool is not designed for patients who have a BRCA1 or a BRCA2 mutation. If you're a patient that fits into that bucket or that category, we already know you're at the high risk, and we're going to take proper measures and going to offer you different things just because you have that BRCA mutation. Also, if you have LCIS or DCIS, and the reason why these are important is because these are like your precancerous cells that are developing. So you don't fully have cancer, but you have enough of these cells being kind of put together to where we know that if we don't address those with radiation and possibly with surgery, that it will eventually develop into full-blown cancer, or invasive cancer is what we call it, where it has a risk of transferring to another part of the body. Also, you look at patients and look at the age. And as I said, as a patient gets older, the risk for developing cancer increases. Also looking at the race and ethnicity, this tool has been validated in several places as far as ethnicity is concerned. While initially it was certainly validated in white women to begin with, the other populations, Hispanic population, white population, African American population, it's been validated in those populations as more patients have been gathered and more risk assessment has been done. Also looking at breast biopsies, the more breast biopsy a patient undergoes, that increases the risk. And definitely if a breast biopsy comes back with atypical hyperplasia, that also increases the risk of them developing invasive breast cancer over their lifetime. And then also the first menstrual period. So if it happens early on, then a patient has had an increased time that they have been exposed to hormones, which increases the risk of them developing breast cancer. If a patient, you notice the next question is talking about a woman's age when they give birth to their first child. The earlier that is, and the amount of children they've had, that also affects the amount of lifetime hormone exposure. The smaller amounts of hormone exposure, when you compare one woman to the other, the less hormone exposure, the less the risk of developing breast cancer. So very important thing that is incorporated into the Gale model for patients to be able to assess these types of things. And then lastly, as I said, first degree relatives, mothers, sisters, daughters who have developed breast cancer. Also, the more of these individuals that are linked to you directly develop breast cancer, the higher risk you are developing breast cancer as a woman. And this is just showing you and kind of rounding off that when you look at the chemo prevention, tamoxifen and raloxifene are your two top drugs that we usually recommend. Patients would take them for 5 years, and we, as you know, I would, as a pharmacist, would make sure, of course, I inform my patient about all of the toxicities and the things to worry about, but also making sure the patient understands that you see that you're at this 1.8% patient risk, as you see at the 5-year mark. Once you get above like the 1.67 or 1.66, you're considered to be a high risk, and that's when it would be appropriate for you to at least be offered these medications. And as I said, with this NCI tool, you can do this as a patient yourself to assess it. If you answer these questions and you see that you're above that 1.66 or 1.7% range, then it will be something to begin the conversation with your PCP. And then from that point, if it progresses forward, certainly I'm going, either being prescribed there, being prescribed by an oncologist. But that 5%, that 5 years of taking these medications can certainly be beneficial to you. Several studies have shown this to be true. So going back, prostate cancer. So looking at prostate cancer, as I said, patients' ethnicity actually is affected by prostate cancer, also family history. And when I say race, specifically talking about African American patients having a higher risk of developing prostate cancer even at a younger age. Also genes. So, you can have gene mutations actually that increase the risk of developing prostate cancer. I have finasteride, which is a medication. It does have data to say that it does prevent, if you can take it for 7 years, you can prevent the incidence of prostate cancer. The reason why it's not commonly used and why I want to this is one thing to dispel, is related to what does it do to patients who are diagnosed with prostate cancer, and how advanced or aggressive is their disease. So that's where the conversation and the disagreement on to use it or not use it comes from. Also, physical activity is beneficial when thinking about prostate cancer. Maintaining a healthy weight, diet that has high amounts of vegetables, because those phytochemicals that we talked about at the beginning, very important, and also foods that are low in fat. Now, lung cancer, which of course, as I kind of alluded to, is a challenge. The only thing that we truly can control, and it's not 100%, because there are patients that develop lung cancer that have never smoked a day in their life. But we know that there is a strong correlation and link between lung cancer and smoking. So the use of any tobacco-containing products, avoiding that, staying away from secondhand smoke, keeping your cars and homes smoke-free. Chemical inhalation is something that they've banned a lot of the exposure that you would use to get chemically to inhaling toxic chemicals from things that are in ceilings, things that are in building walls. So a lot of those places that had those type of chemicals, they've been knocked down and rebuilt, or they've been condemned to where patients, where we know that link is available there. And still also link verifiable fruits and vegetables and healthy eating patterns for lung cancer, but no specific medications that you really could identify. And then colorectal cancer, as we kind of round off, before I talk just briefly about cervical cancer, before I open up the floor for us to have maybe a Q&A session. Just looking at low physical activity, smoking, inflammatory bowel disease is also a high risk, not something that you can prevent, but something you definitely can make sure is treated. But it certainly increases the risk if you have any type of inflammatory bowel disease, and that could be something that affects your stomach, your throat, your intestines. So various places where you can identify that inflammatory bowel disease. It's also linked to family history. And then Ashkenazi Jewish patients, as well as African American patients, have an increased risk of developing colorectal cancer. Increasing the amount of fruits and vegetables in your diet, decreasing red meat, regular screening, especially if you have polyps that need to be removed. And when they do your screening, which is your colonoscopy, if they do identify polyps, and making sure they're removed in a timely fashion, that can decrease the risk of you developing invasive colorectal cancer that can possibly spread to another area of the body. And then consistent physical activity. And then I end with like the medications, because we do have certain medications that have been studied in high risk groups of patient populations. Calcium supplements, which they have studies to say they can possibly decrease the risk of advanced lesions by 20 to 30%. Taking aspirin, got a study to say to decrease the risk of advanced lesions by 30%. And then celecoxib, which is only given, as I said, to these high risk patients who are in a certain category because they make hundreds of polyps possibly in their intestines. So I say all this to say that the calcium and the aspirin is something that is over the counter, but you have to be in a high risk category for it to be something you ain't employ. And that's the conversation that I recommend having with your primary care physician to begin with. And if you do get to the point where you are that patient that is high risk, that does have those polyps that are recurring and that can form, the celecoxib has data and is recommended to take on a daily basis, and it can decrease the risk of an advanced lesion occurring at up to 74% of the time. So it's certainly something that's out there, that's available, that I've seen utilized in the clinical setting for those patients that fall into that high risk category bucket. So just wanted to touch on this as I end talking about the HPV. So some of you on the call certainly would have been offered Gardasil, maybe if you've talked to your OB-GYN. And depending on what age you are or what age you were, if you hadn't been offered it, because like when it became available, you were already kind of out of the age range. Certainly they've talked to you about it with one of your children. It's something that is approved actually in male and female children as young as age 9. There's a 2 or 3 dose schedule that the HPV 9 valent or the Gardasil 9 vaccine can be administered. And it becomes important because when you look at cancer in general with HPV, cervical cancer has almost 100% link to HPV when you're thinking about cervical cancer cases that are being diagnosed. And so this HPV 9 valent vaccine covers 9 of those subtypes or strains of HPV that would cause cervical cancer. 16 to 18 are by far like the most common strains when you like link the cervical cancer to the HPV, but there are others that are actually available in the HPV 9 valent vaccine. So when you look at the numbers, like 63% of the cases could possibly be linked to HPV 16, which is one of the 9 strains that's in the vaccine. So I mentioned that so the patients that you as a patient are informed that it's not just female patients. It is male patients as well, because you see anal, head, and neck cancers are also linked to HPV. But just the idea or the ability to be able to vaccinate your child sooner rather than later, you see up as young as age 9, to protect them against these types of cancer specifically. And just my references there as I gathered information from various sources. A lot of these places are definitely available to a patient, but the National Comprehensive Cancer Network, the American Society of Clinical Oncology, Hematology Oncology Pharmacists Association, the NCI, and then that breast cancer risk assessment tool. That online calculator is on the NCI website. And I thank y'all for y'all's attention, and would love to go back and forth or have a conversation if there are any other questions.
Thank you, Dr. Hunter, for that very informative presentation. So now we're going to go on to the question and answer session. And so before I start that, I'm going to introduce today's moderator. This is Edith. She is a nurse practitioner. She just recently started with us at Texas Southern University. She has extensive experience in primary care nursing education, community health, and clinical research. She holds a master's degree in nursing from the University of Texas Health Science Center in Houston, where she's also pursuing her PhD with a focus on preventing and managing gestational diabetes. She also holds a bachelor's degree in nursing from Prairie View A&M University and an associate's degree in applied sciences, a licensed vocational nurse certificate from Houston Community College, and a bachelor's degree in mathematics and education from the university in Nigeria. And so her commitment to public health is deeply personal, driven by the loss of her father to diabetes and heart disease, and her only sister to the complications of gestational diabetes. She aims to improve patient outcomes and public health by integrating clinical practice, research, and patient education. So thank you so much, Edith, for being the moderator for today's webinar.
Thank you very much, Brittany. Thank you so much. Thank you, Dr. Hunter, for sharing your invaluable knowledge and expertise on cancer prevention. We really appreciate that. I have a few questions for you, and afterwards, we'll be taking questions from our participants. Okay. All right. So my first question would be, what role do pharmacists play in cancer prevention, and how can they educate patients on reducing risks?
Absolutely. I think that where you see a lot of pharmacists, and probably the most accessible pharmacists, is your pharmacist at your community pharmacy setting. And that's somebody that, the patient has a cough, they're going to go talk to them. A patient has You know, there's something, they have a rash, they go talk to the pharmacist. There's all of these things they go talk to the pharmacist about in the community. And like me as a faculty member at Texas Southern educating students, a lot of the tidbits of information that I give, like in this presentation, I talk to my students about this as well. This affects patients, this affects your family members, a lot of different people that are affected if you understand and you possess this knowledge. So pharmacists, they can be in a community setting, like in a community pharmacy setting, and talk to patients about different types of cancer prevention, because there's certain things that are identified. And why I went over all of those risk factors that you in those settings as a pharmacist are easily able to identify. And then when you go even further into it, if you will, when you're in the hospital setting, which I work in a hospital as well, you have even more clinical information on the patient, you can head those patients off at the pass as far as identifying that they may benefit from more common screening or more frequent screening, or actually being screened altogether. We have the privilege, we're blessed at Texas Southern University to have a mobile unit that we're going to have at Texas Southern that'll be able to screen patients in any part of the city, as well as we've been doing cancer screening at Texas Southern since 2018. So it's all been pharmacists ran. So we're probably one of the most unique institutions in the country when it comes to cancer prevention, because we just have an interest in a knack for getting into the community and also impacting the community positively when it comes to cancer prevention. And that starts with screening. Before they ever get a medication, we need to identify the patient that needs additional screening, or identify the patient that might benefit from taking possible medications to prevent the risk of them developing invasive cancer.
Thank you very much for that answer, Dr. Hunter. Now, I'm going to go to the next question real quick, but please, if you are on this program, please, if you have any questions, use the Q&A box for your questions, and we'll be more than happy to take them. Now, can you explain the role of nutrition and diet in cancer prevention? I know you talked about phytochemicals. Would you mind telling us a little more about phytochemicals? Because I'm sure a lot of us are probably hearing that for the first time. And how can pharmacists ensure that patients are making healthier choices and not taking too much of these phytochemicals actually?
Absolutely. I think this is where it comes into play of us being a partner, like us being partners with our patients. And when I say that, I mean, you heard me several times when I'm talking about those phytochemicals and those antioxidant effects, how I'll maybe hone in on that, because those are where I always see the most risk of it being a problem with something the patient is taking that's actually there to treat their cancer possibly. Is a partnership. So if a patient decides that they do want to take something maybe that they identified or they saw on an infomercial, or a friend recommended it to them, us being able to take that particular medication and see what mega doses of the respective phytochemicals it more than likely probably has, and then being able to say, yes, this is safe, or no, this is not safe, or yes, this will possibly interact with something you're taking, or no, it won't interact. So that an analysis of the integration of two different drugs or phytochemicals with prescribed medications is something that's very important for the pharmacist. And the promotion of the healthy diet and the consistent physical activity is a strong link with every single cancer that I talked about today, which I chose like the top four that as far as incidence is concerned, in minority communities and even in the majority communities as well. I mean, it's just in general, they are the most commonly diagnosed types of cancers, and all four of them are linked to physical activity or lack thereof.
Thank you very much once again for that very useful information right there. Now, what advice can pharmacists offer regarding a safe use of supplements and vitamins? I know the previous question kind of touched a little bit on this, but we're talking particularly about those marketed for cancer prevention, like you had mentioned earlier.
Sure. I think because of so this is what I find. And like I say, I do analysis like pretty much anybody in my practice, the oncologist is going to send them to me if they won't approve the patient taking anything that is over the counter unless I analyze the drug. And what I do when I'm analyzing the drug is take whatever medication, and I try to tease out the proprietary blend of the supplement the patient is taking to analyze if there's a identifiable drug interaction or something that causes the side effects of the treatment the patient is on to be worse. And I give you an example is bleeding. So some drugs and some of those supplements, they increase the risk of bleeding. Well, that's a big problem in my patients if they are actively receiving treatment because we give them medications that also increase the risk of bleeding. So when I identify a crossover or overlapping side effect, it's a reason why I would possibly tell a patient not to take the medication. Or if I identify a pathway that the medication that they're taking is interrupted by the supplement, then I also recommend they don't take the medication. And I have several databases that I will analyze these medications in. So if the patient is really wanting to take something, especially if they are taking it, quote unquote, to prevent cancer, I think the first thing to do is to check with your healthcare provider or a professional, whether it's your pharmacist or your physician, or because now I know not everybody just has access to a clinical pharmacist, but your pharmacist in the community can also possibly do this or help you with this. And it's just to make sure that it's safe. You might be on a medication where this causes problems with the blood pressure medication that you're on. It's not even about cancer, but if you're taking those supplements and it's not being run by a healthcare professional, your pharmacist, it can definitely cause more hurt than harm. It can cause more hurt than help.
Thank you so much, Dr. Hunter. And I'm really glad you mentioned blood pressure medications because it's a very common thing out there for people to take supplements and other foods that actually interfere with the medications that they might be on. So I'm really glad that you mentioned that right now. Now, the next question is, how do you approach counseling a patient about the potential cancer risk associated with long-term use of certain medications like NSAIDs and statins, especially when the patient really needs them?
Right. So I've identified that a patient is on a medication that I know possibly has increased risk in developing cancer, like later on in their life, I'm always focused actually on screening. So the screening recommendations, like I'm talking to the patient, I've frequently been in the community setting of pharmacy and be like, hey, I like, because you can easily typically tell if a patient regularly comes to a pharmacy, for instance, if they've had a colonoscopy. So once they're at that age 50, no matter who the patient is, and of course with African American patients, you can even get the colonoscopy earlier, but at minimum age 50, I expect to see a prep kit for a colonoscopy on their profile. So there's at times, and this of course I couldn't do this with every patient, but I typically would try to look and see in their profile over the past couple of years that they got a colonoscopy prep kit. And when I come to counsel them, maybe about, especially if they're on a medication that I know can possibly have that link or has some type of possible increased risk, I just briefly just ask them, hey, you talk to your PCP about getting your first colonoscopy just to get a baseline for your risk of developing colon cancer. Maybe they didn't know about it, which is 9 times out of 10 that's the case. Or the other times is they don't go regularly to their PCP anyway, which I know that's something that younger, healthier patients are very guilty of. And all of those things are things that I can bring up. I'm always thinking about there's like these magic ages on typical patients, and those are the patients you see very common in the community. You easily can talk about first mammogram, first prostate cancer screening, first colonoscopy to get a baseline for colorectal cancer. All of these things are things a pharmacist can easily do by just knowing the patient's age and gathering some information while they're preparing to counsel them on a new medication that they've received.
Oh, thank you very much for that. I think that brings me to my next question, which would be, how can pharmacists help in promoting the use of preventive screening and early detection? I know you just talked about colorectal
Absolutely.
cancer, but there are a couple of other cancers that we might just want to touch on.
Sure. So I think first thing is identifying, because I try to spend a decent amount of time about family history. Family history is so important. And sometimes we don't have that information, but that information is the difference between getting a screening maybe 10 years earlier than you typically would in some cases. So assessing the family history of a patient is just as important as recommending the respective screening. So we always want to make sure that we have a good historian, or try to get the best historian possible to get the baseline for that family history. And outside of that family history, also understanding that you have certain cancers, and I'm going to use lung cancer, because lung cancer is one that people don't think as much about because it doesn't have as much of an impact as far as medications are concerned with cancer. But there are aggressive screening recommendations when patients have a certain length of time that they've been smoking. So understanding that even if you're talking to somebody you know that smoked for long periods of time, whether it's a family member or a patient, and understanding that they could possibly benefit from low dose CTs of the chest. And that's something that's important, because detecting lung cancer early on is the key to preventing the patient from dying of it, because once it gets advanced, it's one of the most toughest cancers to treat. And then there are no medications that we can recommend, like with colorectal or prostate or breast, that can prevent lung cancer.
Wow. Wow, that's really insightful. Now, my next question would be, how can pharmacists work with other healthcare providers to ensure that patients are receiving the best care possible? Now, I know very much that not all the patients that we see have primary healthcare providers. So, how can we, or how can pharmacists bridge this gap?
As I said, and I mean, I worked in a community pharmacy setting for 22 years, if you can believe that. From age 17 to age 39, I worked in a community pharmacy setting. So I'm, going on 3 years removed at this point. But in that setting, I had I had this access to patients that you just don't typically have, because no matter where patients go all over the place, and this physician, this nurse practitioner doesn't know what that physician did. That physician doesn't know what that physician did. The pharmacy is typically the only place where you hope that the patient is at least going to the same pharmacy consistently throughout the time that they are receiving a treatment, for you to be able to bring all of their disease states together, all of their medications together, and possibly all of their risk factors together. Because if they're either not a great historian, where they don't give that information when they come to the visit for whatever reason, or it's just something that slipped their mind or something they didn't think about. A lot of times you have all the information as the community pharmacist that's filling all of the patient's medications. So I always found opportunities when I was in the community setting to impact the patient positively, to bring our parties together. Be like, hey, did you know this patient was on this? Because you're prescribing something that directly interacts with this. The insurance companies help out with this too, where they have like managed care pharmacists that are seeing the claims that are being paid on the insurance side, and that can possibly help. But even that doesn't always like clinically and therapeutically pick up every single possibility of there being a possible, negative drug reaction because a patient is taking medications together that shouldn't be taken together, or has a disease state that interacts with the medication that they're taking. So I see community pharmacists at the top of the list as far as somebody that can bridge the gap between different healthcare entities to take care of patients at a higher level.
Wow. Okay. Thank you very much, Dr. Hunter. I have a few more questions. I hope you don't mind.
Yeah.
Thank you. Now, what role do pharmacists play in counseling patients on the use of preventive agents, such as tamoxifen? I know a lot of people might have some concerns. Why do I have to take this medication if I don't have breast cancer and all that? So, how can pharmacists counsel patients in this regard?
Yeah, so I cancel a lot of patients on tamoxifen, because actually one of my subspecialties, I'm an oncology pharmacist, but I subspecialize in breast cancer. So there's always, a laundry list, unfortunately, with tamoxifen I had to talk to patients about. And I'll tell you, probably 3 out of 10 patients are like, after they get done with me, they don't want to take the medicine anymore, unfortunately. But I'd rather a patient be very well informed and understand, versus coming through a process and not being informed. Because I feel this their right as a patient to understand exactly what we're giving them, exactly what we expect as far as side effects are concerned. And I offer solutions as well as problems. So when I talk to them about specific side effects, I also talk to them about ways to identify if these side effects are occurring, so that we can address them in a timely fashion. So I think as a pharmacist, your responsibility is, of course, not to withhold information from a patient when it comes to like starting them on something, but also offering them the benefits of taking the medication for them in general as an efficacy perspective, or how well the medication is going to help them. And then also if they have, side effects that are common, what are the solutions to those particular side effects to possibly help to, navigate through if it's something that causes, let's say increases the risk of blood clots. Okay. So what should I be looking for because blood clots are treatable. It's not like they're not a treatable, but they can become a very serious situation if they go unchecked for long periods of time. So it's having those types of conversations with the patients. I don't just give them side effects and then that's it. I talk to them about ways that if a patient gets this side effect, they possibly, then we can do this, or we can do this, or we can do this, or we can do this, and making sure the lines of communication are open so the patient understands, let me know when you have these changes and these shifts, and then we can get on top of it and address it.
Wow, thank you very much. So that sounds like open, honest communication. So the patient doesn't wake up to surprises, huh?
Yes.
All right. Thank you very much, Dr. Hunter. Now, one more question. What are some emerging trends on new medications in cancer prevention that pharmacists should be aware of in their practices?
Sure. So we're doing quite a bit actually with the vaccines. I mentioned one vaccine, but they are trying to take some of these vaccines and even go a step further when it comes to prevention. So identifying the, if you will, that high risk patient, and then identifying the root cause of the cancer, and then trying to create vaccines that either can simulate that cancer to build up antibody formation that can then attack the cancer cells if they do appear, or in a situation with cervical cancer, which that's a very, very commonly diagnosed cancer worldwide. But in the United States, we have cases that are below 25,000. So, to put this in perspective, you can see numbers as high as 500,000 on other continents. But in the United States, specifically in our country, where we've got that number down to less than 25,000. And it's not just the vaccine, it's also the prevention from the pap smear and identifying atypical cells early on. But the vaccine is certainly something that is even a level above the screening, to where the screening maybe will cause you to get some atypical growth and you remove it early on and then they don't develop invasive cancer. The vaccine is addressing the whole reason why a patient would develop cervical cancer and destroying it and stopping it at that point. And that is like something that they're definitely trying to look at ways to duplicate that in several settings, and looking at different risk assessment tools to utilize medications early on versus later after a patient has already developed cancer.
All right, thank you very much. I got some questions from the audience. And the first question is, there are some foods that are even labeled as healthy, but they have cancer causing warning labels. How can those be accurate? And can you give us an example of a patient's journey from the time they got a screening at one of the events to treatment stages?
Sure. So I guess let's start with the food first. Let's start with the food first. So the food, they have a tendency of definitely, and I know everybody has been to Whole Foods and they've been to HEB and they've been to Kroger, and you got this is organic, this is not organic, this doesn't have GMOs, this doesn't have this chemical, this has this chemical, so on and so forth. So unfortunately, a lot of chemicals, not just vegetables and fruits, even with the meats, they are using carcinogens. Unfortunately, we're being exposed to inadvertently when we're eating certain foods. Is it how much? What is the amount? Very, very small amounts. Have we done studies to show what the cumulative effects of it is? We don't have those studies to say that it does or it doesn't, but we know that they're definitely there. So a lot of times, like, you're talking about those organic or those, maybe you got the cage-free chickens and you have all of these different things. People kind of glaze over that and don't really maybe look at it as being such an important thing. But if you're taking anything away from my presentation today, that understand that we kind of are what we eat, if you will. All of the higher quality, the better foods that you're eating, the foods that are exposed to the least amount of pesticides and chemicals, all of those things are positive for you in the long run, because they're just small incremental increases maybe in your risk. But if you continue to keep adding these small increments consistently, daily, they can be either, they can negatively affect you if they're positive things, if they're negative things, and they can positively affect you if they're positive things. So 10, 15 minutes of exercise every day can affect you in a positive way. Consistently exposing yourself to a carcinogen, even if it's a very small amount, in the long run can affect you in a negative way. So I think it's just being mindful of what you're eating, negative things that you're eating, things that possibly are carcinogens, and then also understanding that your diet and your health and your physical activity also are at the top of the list as far as things that you as a patient can control. And to address your second one about a patient who went to a screening event. So yes, I won't. Yeah, I'm trying to think how I can. Well, I'm just, this is just a scenario. So it's a scenario because it's the actual patient, but I'm just thinking about, like, this HIPAA. But let me just give you a scenario. So like I said, we've been doing this program since 2018 when it started with Susan G. Komen. That gave us our first funding. A couple years after that, Dr. Adjorole took the breast cancer. I'm talking about the Breast Cancer Screening and Prevention Center now. Dr. Adjorole took it over and grow has grown it to a point that we could have never imagined, or ourselves. Only God could have done what we have at this point, where we have a mobile unit, we have a robust group of individuals that work on the project to grow it. And what we have been doing early on is that a patient was screened in the community and they had an abnormal screening that came back. We analyzed all of those, myself and the oncologist, when we were much smaller. And if they were somebody that needed to be triaged to get a diagnostic mammogram, then we would send them there. Once we sent them there, our funding stopped. We couldn't do anything else after that. We send them there, and they would work with another organization to get more additional screening to possibly diagnose. So we did have we have had patients that have gotten screened in the community, had to then be navigated to a diagnostic mammogram, which then came back where they did need to get a biopsy. And once that biopsy was confirmed to be cancer, we're able to be diagnosed at the stage 1, as opposed to being diagnosed at stage 2 or stage 3, which requires a much more advanced treatment, a longer treatment, and a more aggressive treatment. So instead of just having a lump removed, having to have your whole breast removed, having to get radiation, having to get chemotherapy for a year, all of these things were circumvented, or we avoided those things by identifying that patient in the community, and then going all the way to the point where they were diagnosed with DCIS, which is ductal carcinoma in situ, and just having to get that removed and maybe get some radiation. So we've seen several cases where patients early on were identified, and we identified them and caught them in the community, as opposed to them having advanced disease and coming in when it's really, really bad.
Wow, thank you very much, Dr. Hunter. We are trying to be very cognizant of our time. I have 2 more questions and we will call it a wrap. So the second to the last question is, in your experience as a cancer pharmacist, how do pharmacists, what are the most common misconceptions that patients have had about cancer prevention, and how would you advise pharmacists to correct them?
Yes. So I think when patients think about cancer and they think about taking a medication for cancer when they don't have cancer, it's something that's hard to wrap their mind around, because they're looking at it like, why are you trying to, what are you trying to put on me? It's like, I don't have cancer. Why are you trying to give me treatment for cancer? And why would I need prevention? Like, what are the things that would cause you to believe that I need to take this additional medication for prevention? And I always talk to my patients, and this is like, I had to have this same conversation with every patient that I start on treatment, chemotherapy, after they've had surgery, is that the whole point is to prevent the cancer from either coming or prevent it from developing altogether. So in the prevention place, we're really talking about preventing it from developing altogether. So I usually I run down, and of course I specialize in this, so it's maybe a little bit easier for me to do it, but I just run through the gamut of, we have 2 paths we can take. Like, and it's not, and it's not saying if you don't take this that you won't develop cancer, but maybe here is the percentage of benefit that you're going to get as a patient if you do take this treatment. And if you don't take this treatment, and let's say we go down the other path and you're one of the, maybe 20% of patients that do develop cancer because you didn't take the preventative. So these are the things that we would do with you. So I'm trying to recommend you take this tablet right now, for say. Okay, so you're going to take this tablet for 5 years, and it comes with its own group of side effects. So I'm not going to say it's completely inactive or it doesn't affect you in any way. But at the same time, you have this tablet for 5 years, or you have going through an actual surgery where you have to be put under anesthesia. You have to get radiation for 5 weeks. You have to get chemotherapy for 24 weeks. You have to possibly get targeted therapy for a year. And if you have hormones that are involved, we recommend that some patients take hormones for 7 years after we do all of that. So it's a much more extensive amount of treatment that we have to do if you're a patient that does identify as having high risk, but then you don't decide to go forward with the preventative medications that we know have significant differences as far as benefit is concerned.
Wow, thank you so much, Dr. Hunter. It's been a pleasure having you on the program. Everything you said has been very insightful, and we have learned a lot. I'm going to pass this on to Brittany to continue with the rest of the seminar. Thank you.
Absolutely.
Thank you so much to Edith and Dr. Hunter. That was an amazing question and answer session and just an overall really good presentation. A lot of good information. So just 2 quick things before we wrap up today. Let's see. So unfortunately, our clinical research engagement conference got postponed due to unforeseen circumstances. And so we will provide updates as soon as they become available. We appreciate y'all's commitment to that. And on the other hand, we have our upcoming CEC events, the Let's Talk About Prostate Cancer and War Against Breast Cancer. Those will be happening in September and October. So please scan the QR code or yes, it's just the QR code right now to register. We really look forward to seeing you guys there. Thank you so much for joining us today. Thank you again to Dr. Hunter and Edith. That was an amazing presentation, and we hope you have a great day.
Y'all as well. Thank y'all for having me.